Greetings to Intro to Pathophysiology and Hemostasis Disorders. So the first part of this PowerPoint is going to encompass learning outcome number 1. So we're going to talk about the terms and language that is used in patho, and we'll explain different categories of etiology, which is the causes of disease. So pathology is a focus on the physical changes, but pathophysiology is the abnormal functioning of disease organs and how it applies to medical treatment. Or in other words, pathophysiology is signs and symptoms, treatment, and what the healthcare professional is actually seeing. Pathophysiology is really more the unseen. What is the underlying cause that then promotes these physical signs and symptoms? So disease is the loss of homeostasis, and that's an important point. When you took normal anatomy and physiology, then you had these negative feedback loops. And so if a person's heart started to race, there would be a sensory neuron that would fire to the central nervous system, and then you would process that information, and then it would then fire a motor neuron that would give some effect that would be the opposite. So in the case of a high heart rate, the result would be the effector neuron would then put a brake on the heart rate, and it would slow down the heart rate. So a negative feedback means the opposite. And then you would get back with a lowered heart rate to homeostasis. The thing with pathophysiology is that there's something that's broken and you don't get back to homeostasis. And whether it's acute or chronic, then there's usually a cascade effect that is going to happen that's more of a positive feedback, so things get worse, not better. Etiology is the cause of the disease. It is not uncommon for a disease to be of unknown origin. So that would be an idiopathic disease. So during this semester, we will be talking about idiopathic diseases versus diseases that have no causes. We have categories of etiology. Often genetic diseases are inherited. So cystic fibrosis, when we talk about pulmonary diseases, it's the most common inherited disease that in the United States, cystic fibrosis. So we'll talk about how it gets inherited when we cover that. Congenital diseases tend to be inborn diseases. Sometimes it's a problem with or an exposure to pathogens or other toxic substances during a pregnancy, and sometimes it's known, sometimes it's not. So fetal alcohol syndrome is a good example of that, and it's the excess alcohol that can pass the placental barrier, then that can affect the growing fetus. Acquired is what most of us have. That's going to be some sort of environmental thing that's going to impact a disease process after birth. And a syndrome is important because it's going to encompass more than one organ or tissue. So Down syndrome is an example, and syndromes are a combination of signs and symptoms. So with Down syndrome, we very often think only about intellectual impairment, but more often than not, that trisomy 21, having an extra chromosome 21, is going to cause other things. So often a child will have heart defects, they'll have gastrointestinal problems, they can have thyroid disease, early onset heart disease. So since it's not just one thing, it's not the central nervous system only, it can also be pulmonary, it can be cardiac, it can be gastrointestinal, it can be endocrine, and those make up a syndrome. pathogenesis. Genesis is the birth of, and patho, right? The birth of pathology. So what are the sequences that are going to, in the end, have a disease develop in the body? Now, a sequela, on the other hand, is an impairment resulting from the disease. Very often, we talk about sequelas with chronic diseases. So it might be a decade out that a person is going to have kidney disease, but the actual underlying cause of that is going to be long-term consequences of diabetes. So long-term consequence of atherosclerosis could have an impact, and the person could have a heart attack, or a person could have a stroke. And so that's a sequela. So the stroke is a sequela of long-term atherosclerosis. Kidney disease can be a long-term consequence of diabetes, etc. And then we get into acute versus chronic. So acute is sudden, rapid onset. It tends to be focused as far as hours or days, perhaps weeks, that's about it. Chronic conditions are going to be months, years, decades. And you can have a disorder that causes lesions in some of the tissues of an organ. If the lesions, could be tumors, for example, is localized to one part, then that's called local. Sometimes you can have pneumonias that are said to be lobar pneumonia, and that's located just in one lobe of the lung, and it's not either diffuse, where it's throughout the lung. It's rather focal, so it's just that one lobe. Systemic means often things start off locally and can get into the bloodstream and become systemic. And that background is my cat meowing. And so local would be confined to one area, systemic throughout the body. Focal is going to be just a very one area, let's say of the lung, etc. Diffuse would be throughout the organ. Okay, so learning outcome 2. The thing that I wanted to mention right about now is that you do have the ability to stop whenever you want to, take notes, and then continue. So when we get to the learning outcomes, that's kind of a great pause. So in this next section, we're going to be talking about how cells can get damaged, and then how do we refer to them when they become damaged. So atrophy is a shrinkage due to decrease in cell size. Sometimes you have a situation where a person might break a bone and they're in a cast for a while, and they're told to stay off of that leg or not use the arm. And then when the cast comes off, there's a shrinkage of because of lack of use. You don't lose the muscle cell, you don't lose the skeletal muscle cell, but that starts to atrophy and get smaller. And it's actually the cells that are getting smaller. They don't die. The cells can actually get larger again when you exercise after the cast comes off, but you could have the cells actually shrink a bit because of lack of use. So that goes in decreased use, blah, 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 blah. So the next one is hypertrophy, and that's an increase in cell size. This is going to be something that we'll talk a lot about when we get to cardiac, because the heart can get large, or a chamber can get large, and it's not that more cells are being made, but that the size of the cell gets larger. So the largeness has to do with increased protein synthesis. You could also have it be describing bodybuilders. When they're trying to bulk up, they're not getting more muscle cells. They're actually, through their exercise, making the cells increase their protein synthesis and increase their size. So that is the reason for the largeness of the muscle. And that is hypertrophy. Now, hyperplasia is the opposite. In hyperplasia, you actually are increasing cell number, and that's due to an increase in cell division. So endometrial hyperplasia in the uterus, which may be a result of ovarian tumor, means that you actually are making more and more of these endometrial cells. And that is hyperplasia versus hypertrophy. Metaplasia is the replacement of one cell type with another. So let's talk about smokers. If you are not a smoker, your upper respiratory tract is lined with these beautiful ciliated columnar epithelial cells that move bacteria, pathogens out of the upper respiratory tract, and they beat in such a way that the pathogens are going to come into the mouth. You can sneeze them out, you can cough them out, you can swallow, but they are there to continually get rid of any sort of invading microbe that might want to inhabit the lower respiratory tract. With a smoker, especially long term, the chemicals in the smoke, the toxic chemicals in the smoke, will actually over a period of time cause the cells, they still are epithelial cells, but they are no longer columnar ciliated epithelial cells. Instead, the toxins will start to alter the genetic code in such a way that these epithelial cells become stratified squamous. They're very flat, there's many rows of them, and they have absolutely no cilia, and they have no capability of flushing out and moving out of the upper respiratory tract any sort of pathogens. Very often a compensatory mechanism is the smoker's cough. So if you don't have these ciliated columnas to get rid of all of that pathogens, the smoker's cough is a way of trying to do that instead. But what is happening to the smoker is metaplasia. Over a period of time, the ciliated columnar epithelial become stratified squamous. They're still epithelial, they'll still line the upper respiratory tract, but their function now is quite different. All right, the last two, dysplasia and neoplasia. Let's do neoplasia first. Neoplasia is malignancy. It's a malignant tumor. It's a tumor that, and we will talk about this in class face to face, but a malignancy means that transformation of a normal cell into a neoplastic cell means that it can then metastasize and affect other organs, and if not stopped, can result in death. Dysplasia, on the other hand, is something quite different. It's a change in a cell, resulting in abnormal cell size, cell shape, or differentiation. I would underline differentiation. What happens is that there are a number of cancers that have precancerous states, and the cervical cancer is one of them, which is the reason why women get pap smears. And what they do is they will scrape the lining of the cervix, and then a pathologist will look at those cells. And what the pathologist is looking for is really a lack of differentiation of these cervical epithelial. So the dysplasia means that the cells appear less mature. We'll find out later that one of the things that happens with cancers is that the cancerous cell becomes autonomous. It loses its ability to respond to the signals of the tissue of the cell or the organ system, and they become more embryonic-like. And that is considered to be dedifferentiation, or the cells become immature and they start to lose their function. And they are coming down that road or going down that road towards a frank neoplasia. Often, if you can catch it in the precancerous stage, you can catch it when it's just dysplasia, it's not a frank cancer yet. Then if it responds to treatment, then the cells can return to their normal, highly differentiated state. But dysplasia is usually a sign that the cell is dedifferentiating, it's becoming very immature, it's losing its specific function, and it's going down that road to frank cancer or neoplasia. So learning outcome number 3. Define and explain ways cells can be injured and some epidemiology terms around disease and pathophysiology. So, whenever a cell is injured and it cannot maintain homeostasis, it runs out of its bag of tricks, then you can have disease. So the cell injury can be a lack of something. So you might need a certain vitamin or a certain cofactor for the cell's metabolism to work properly. So that deficiency, let's say of iodine, that would mean that the thyroid wouldn't have a vital component to making their hormones like thyroxine. Intoxication or poisoning. So there are a lot of toxins out there that can either poison a certain organelle or cells. So, for example, you could have cyanide poisoning where the mitochondria then just don't make energy and then the cells die. The other is trauma, and very often it's physical injury. So you're in a car accident and you have trauma because of the accident to your legs, and it affects skeletal muscle, it affects bone, and then that type of traumatic injury is what is causing the cells to be destroyed or not to function. Deficiencies. And I'm going to click on this and get everybody up here. Okay, we're almost there. Ta-da! Over and over again for this next 6 weeks, you're going to hear me talk about oxygen. It is so important. And so why is oxygen so important? Oxygen is important because when you can't store it, you can store glucose. You can store it in the form of glycogen in your liver and your skeletal muscles. So if you skip meals and you can't eat for whatever the reason, then you can still have a blood glucose level that's normal. You can't store oxygen. You have to breathe. And when you stop breathing, you die. The reason for that has to do with cell respiration. Every cell in the body wants to do cell respiration, needs to do cell respiration, and if it can't do cell respiration, it will die. Cell respiration is taking glucose and oxygen from the blood at the capillary level. They will diffuse out and into cells. The cells then do cell respiration, also called aerobic respiration, and that's where they make 38 energy units in the form of ATP. Without oxygen, they make 2. 38, 2. Guess what? You need the 38 because cells need to divide, they need to synthesize, they need to repair, they need to express. And that's where they get most of their energy. Yes, they can do other things. Neurons will make neurotransmitters. Cells in the pancreas will make digestive enzymes. But every cell absolutely, positively depends on oxygen and glucose and cell respiration to make most of their energy and building blocks. If you don't give it enough oxygen and glucose, then you're going to either have the cell become diseased or die. So there are 2 terms, hypoxia and ischemia. So ischemia is inadequate blood supply to a cell or tissue. Because the cardiovascular system is the main route for moving molecules around like oxygen and glucose. If you don't have a robust blood supply to a certain area of tissues, cells, organ systems, then that lack of perfusion of blood in that area means that you are lacking perfusion of oxygen and the accessibility of glucose. When that happens long enough, then you develop hypoxia. Hypoxia is deficiency in oxygen at the cell level. It's not the only way to become hypoxic. but ischemia is a very common way to become hypoxic. So if a cell isn't able to get enough oxygen and that continues and it cannot be remedied, then that cell will probably die. So whether it's a problem with your respiratory or cardiovascular system, or there's some underlying anemia, which could decrease hemoglobin transport and oxygen transport. Either way, if a cell does not get a continuous supply of glucose and oxygen, then and that can be ischemia or other causes, then the cell is hypoxic and then death. Yes, ischemia can cause hypoxia. Now, perfusion. I used it about 30 seconds ago, and that's the passage of fluid through the circulatory system or lymph to an organ or tissue. And it usually means delivery of blood to a capillary bed in a tissue. So if you have good perfusion, it means that you have great blood flow, great delivery of oxygen, glucose, metabolites, whatever. If you lack perfusion, then you're cutting off that supply and disease can ensue quite quickly. Sometimes you can have medical causes or surgical treatment or drugs that can actually cause a new illness or injury, and that is said to be iatrogenic. Now, two terms that are used in epidemiology, because whenever you have a disease outbreak like measles, then you're going to have epidemiologists track that disease, and they will use the terms because you're now talking about populations. When you're talking about epidemiology, you're talking about mortality and morbidity, you're talking about a population of, not just one person. So the number of deaths in a population, or the death rate, is called mortality. Now, even though morbidity sounds like mortality and the beginning is spelled the same way, that is quite different than death rate. So this says refers to having a disease or symptoms of a disease or the amount of disease in a population. So morbidities are not death. Morbidities can range from Alzheimer's to cancer to traumatic brain injury. So because the young lack immune capability, the morbidity of viral upper respiratory disease reaches 100% in kittens in a litter. You never guess I have cats. Or morbidity rates for polio plummeted in the 21st century. Another thing about morbidity could be the morbidity in the United States of people developing cardiovascular disease is quite high. So it's not death, but it is how a disease is playing out in a population. Now, learning outcome 4. There are two terms that are going to be used a lot this semester, and one is apoptosis. You don't pronounce the second P. And the other term is necrosis. So let's do apoptosis because you're going to find that much more in a lot of pathophysiology than you are going to find necrosis, because it is present in normal as well as abnormal situations. So sometimes when you stop apoptosis, things can become quite dramatic, and we'll talk about apoptosis and how it gets manipulated in cancer. So apoptosis is another term, comes from the Latin. It's cell suicide. Cells, why would a cell want to commit suicide? Also called programmed cell death. So let's take a normal cell, and the cell then starts to undergo mutational changes, and the repair mechanisms are not working. At that point, the cell might decide to commit suicide. It's a very altruistic decision on the part of the cell that's injured, because the cell that's injured would rather take itself out than to then become full-blown neoplastic malignancy. And if that happens, and it happens more than you know, because you don't know it until it doesn't work anymore, and then cancer is diagnosed. Somebody said that if you live to be 18 years of age, you have had apoptotic events happen. Otherwise, you would have been diagnosed with cancer long before that. The thing about apoptosis that's fantastic is that there's absolutely no inflammation that occurs, which is the other reason why you don't know that it's happening when it's happening in a normal situation. Every day you may have many, many cells that are irreparable, and they do apoptosis and take themselves out. There's no inflammation involved. There are actually mechanisms to take away the body, so to speak. And so you are totally unconscious of that happening, but it does happen all the time. In contrast, necrosis, inflammation. Necrosis is cell death that's triggered by an external factor or disease. Car accident. So the person's in a car accident and they break an arm, they break a leg. That is definitely going to cause inflammation. The trauma of the impact is such that the cells just burst and die. There's no decision making that's going to be going on. There's no pondering as far as, can I repair myself, not repair myself, take myself out, commit suicide. It's just dead on impact. And that will trigger an inflammatory response, because now you need the immune system to remove all of that dead tissue. One example that's very often used is gangrene. And so that could happen with a diabetic, where they start to develop a diabetic foot, and the lack of nutrients, blah, 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 blah. The cells then start to die en masse, and they become gangrenous, and the person has to have their foot amputated. So, or it could be caused by Clostridium, whatever. But when you have something dramatic happening from the outside, then that is going to be a sudden death, and it's going to be associated with inflammation. And we'll find during the 6 weeks, we'll talk more about apoptotic events than necrotic events, but the big thing to know is it's a non-inflammatory event with apoptosis, and it's an inflammatory event with necrosis. And now we're going to get to the learning objective 5. Now, the reason why we're going to get into hemostasis in this introduction has a lot to do with the fact that we have to cover so much in 6 weeks. So it's a little bit of a side tour about how you stop the flow of blood and some of the pathologies where this doesn't happen and why. So when you have a cut, a lesion, you pick the knife up the wrong way, you're going to start to bleed because the arterioles, capillaries in that wound area, as it cut through your hand, are definitely, you're going to be losing blood. And yet the blood will eventually stop flowing. And the events that occur are called hemostasis. The first thing that's going to happen when you pick the knife up the wrong way and it starts to bleed is the vascular phase, where you have a spasm of blood vessels. So within maybe seconds, it seems as though nothing's going to happen, and then all of a sudden there's a gushing of blood. So that's the spasm that occurs. And during that period of time, what is actually happening is that the cells that are damaged are going to start to release factors that will begin a event that will take place within seconds, and it's called a platelet plug. And these platelets are kind of the consistency of bubble gum. They're not going to ever stop the flow for any length of time, because it's just not, bubble gum is not the greatest way to stop blood flowing, but it's a very quick way to stem that flow. So even that it's flowing a little bit, it's not flowing a lot due to that bubble gum-like platelet plug. And it starts out small and gets large, but it does have to be replaced with something more permanent. So that takes place in seconds. What takes about 3 to 5 minutes is this coagulation phase and the formation of a fibrin blood clot. This is biological steel. This is something that no pressure is going to reopen that wound. It's going to be the final solution, but it's going to take time. And that fibrin blood clot is dependent on the platelet plug being formed first. And then these platelet plug factors will start the second phase of the blood clot, which is the formation of a fibrin blood clot. Once you've laid down these threads of biological steel, then you stop bleeding and wound healing will commence. So there are pathologies of hemostasis. This is just a diagram showing you how things normally should happen. And there are 2 categories of hemostasis disorders, primary and secondary. I'm just going to take one of each, and certainly if you want to know more pathologies within that, consult the textbook. So primary disorders are going to be abnormalities in the number or function of platelets. And secondary disorders tend to be problems with forming the fibrin blood clot. So the primary, or von Willebrand's disease, is going to be my poster child for this. It's going to be problems with making the platelet plug. The secondary disorders, like hemophilia, are problems with making the fibrin blood clot. Everything hangs as a whole, but the platelet plug comes first, and the fibrin blood clot comes second. But the fibrin blood clot's dependent on the platelet plug forming naturally. So if you don't form a platelet plug, forget about forming a fibrin blood clot. If you form the platelet plug but can't form the fibrin blood clot, you're still not out of the woods because the platelet plug's not strong and it's eventually going to blow. Either way, they are disorders of bleeding. So this is showing you the development in the bone marrow, the red bone marrow, of blood cells. And that is going to include what is called thrombocytes. And they are a term for platelets. They come from a cell with the name from hell right here. It's called a megakaryocyte. Mega meaning big. And karyocyte is a type of blood cell. This very, very large megakaryocyte is formed in the red bone marrow and it matures, but just before it actually moves into the bloodstream, it fragments into hundreds and hundreds of platelets. So a platelet is not a cell. Platelet is a fragment of a cell that contains enough chemicals for them to participate in the formation of a platelet plug if that blood vessel is injured, ruptured, cut open. And the platelets have a finite lifespan. They can either be used up by forming a blood clot or they can age. And then you would have to go back to the red bone marrow, to the stem cells, and it would be a natural replacement. Some of those cells will become, again, megakaryocytes and fragment and form more platelets. It's a very well-regulated cycle, very supply and demand. Okay, so let's talk about von Willebrand disease. Actually, I don't want to do that. Actually, I do. I'm sorry. I was like, which one should be first? Which one should be second? I'm going to do von Willebrand's disease. It is a genetic disorder, so it's inherited, and it is lacking a factor called von Willebrand's factor, named after the fellow who discovered it, and it's going to affect platelets. So the factor that is a key clotting protein is going to disrupt platelet plug formation during the clotting process. Again, if you cannot make the platelet plug, you cannot make the fibrin blood clot, you've got yourself a bleeding disease. In contrast, and this is just going into the whole thing where you have the bleeding disorder, it's inherited, and that the problem is going to be the lack of functioning of the platelets. So that is where you are going to have abnormal platelets, and that would mean that the person cannot clot their blood. Hemophilia is a problem within the second part, which is setting up the fibrin blood clot. So there are two types. They are inherited. It tends to mainly affect baby boys. They can be a damaged gene. The mother has two copies. It's a sex-linked disease, and the daughters are either free of the disease or the carriers. And the sons, however, because they only get the Y chromosome from the father, if they get the damaged or mutated chromosome from the mother, then the baby boy is born with hemophilia. There is hemophilia A, which is missing factor 8. There's hemophilia B that's missing factor 9. It doesn't really matter if you are missing a clotting factor in a cascade that's going to lead to a fibrin blood clot, then the cascade falls apart and the child bleeds. So unable to form a fibrin blood clot, and because of that, tissues and soft tissues tend to be the area where the inflammation is most pronounced, because every time you use a joint, there are little micro abrasions, little micro tears that are just very easily taken care of if you don't have these clotting disorders. But they become a cumulative type of situation, and so there are many, many signs and symptoms that can evolve from the inability to be able to form clots. So there are a number of treatments, blood transfusions being one of them. We now are able to make some of these clotting factors. So the child would take them like a diabetic, takes insulin for the rest of their life. But at least that can ameliorate a lot of the signs and symptoms. And if the gods are good, that's the end. So I will see you next time. And if you have any questions or concerns, please email me. Thank you.